Hello, and welcome back to another episode of Maternal Depression. Let's talk about a podcast.
Today we're going to take a very big turn to talk about a global health topic and intervention that is going on across the world in Pakistan. Today's episode, the treatment of depression in mothers in Pakistan.
Currently, the treatment of prenatal depression is a high public health priority because of its increasing prevalence, its association with disability, and poor infant development.
According to the study, depression is the fourth leading cause of disease burden and the largest cause of non-fatal burden, accounting for almost 12% of years lived with disability worldwide.
In the rest of this episode, we look at the treatment of depression, specifically in rural Rawalpindi, Pakistan, through the use of cognitive behavioral therapy, also known as CBT.
Pakistan is a multi-ethnic community that is located in South Asia and harbors a rich variety of landscapes. Throughout most of its history, Pakistan has struggled to define itself in a political and cultural sense because of ethnic, religious, and social conflicts. These political woes have spilled over into the economy, leaving over a third of the population in poverty.
Studies done within the country suggest that women in Pakistan are more at risk for depression than men, and this can be troubling, especially for mothers.
This is extremely troubling because perinatal depression is associated with high rates of disability, infant malnutrition, and increased rates of infant diarrhea, and the children are less likely to be immunized by their parents.
Oftentimes, it is very difficult to get treatment in these rural communities because of scarcity of mental health professionals in these areas.
There's also a lack of opportunities for people to gain mental health knowledge, and oftentimes women may not even realize they have a mental health issue.
Because of these issues, researchers wanted to determine whether the psychological interventions that community-based health workers delivered would be beneficial and whether or not the intervention could be further implemented into resource-poor settings.
The study took place in two rural areas of Pakistan, Khujar Khan and Kalar Siada, which have a combined population of around 600,000 individuals. Many families in the area are farmers, and each family is normally supplemented by males serving another job.
Now, what were the specifics of the intervention, you might be wondering?
Well, mothers aged 16 through 45 years old, married, and in their third trimester of pregnancy, were split into clusters based on the area they lived in and were designated to a specifically trained lady health worker. The program name for the intervention was deemed the Thinking Healthy Program.
So, how do they pick these women? Well, baseline psychiatric assessment, structured clinical interviews for diagnostic and statistical manual of mental disorders, DSM-4 diagnosis, were conducted by experienced psychiatrists.
Women who fulfilled the criteria for DSM-4 major depressive episodes were recruited to participate in the intervention.
The intervention consisted of a session every week for 4 weeks in the last month of pregnancy. 3 sessions are the first postnatal month, and 9 one-monthly sessions thereafter.
13 mothers in the control clusters received an equal number of visits in exactly the same way as those in the intervention group, but by routinely trained lady health workers, which meant they were not trained in any cognitive behavioral therapy approaches.
Workers from both groups received monthly supervision and were monitored to ensure that they were attending their scheduled visits.
The control group thus received what would be regarded as ideal care, because normally the care patients would receive would never be as routine.
So, why did they even try to implement this intervention in the first place?
Well, as explained in the study itself, evidence from high-income countries show that psychotherapeutic approaches such as cognitive behavioral therapy, interpersonal therapy, or problem-solving are effective treatments for depression. Randomized trials from low-income and middle-income countries resulted in similar findings.
I guess you could call this an evidence-based intervention then.
I would say so. They took evidence that cognitive behavioral therapy is an effective way to treat depression and attempted to build their intervention around said data. We will dive into the outcomes of the intervention in this instance and the statistical analysis of some of the results in a little bit. However, first we want to talk about the future of this episode.
Throughout the rest of this podcast, we want to discuss the intervention in more detail. More specifically, we believe that the use of cognitive behavior therapy-based interventions by local health workers is essential for decreasing cases of perinatal depression.
Now we're going to move into the discussion portion where we'll be joined by a special guest, Dyuit Ganesh, who is a psychology associate in Washington, D.C. and Maryland. She's a specialist in cognitive behavioral therapy, dialect behavioral therapy, trauma-focused cognitive behavioral therapy, and more. She has a passion for using CBT and approaches emphasizing a multicultural, holistic, strength-based approach to mental health. We are so excited to speak to her because of her vast knowledge and passion of CBT practices and get her opinions on our chosen intervention. We are so thankful she is taking time out of her schedule to talk to us.
We hope you enjoy.
Good evening, Dyuit. It is so nice to meet you and to have the opportunity to speak with you. I thought it would be nice to start with something really simple. So as someone with an incredible background experience in CBT, and many other therapy options. How effective do you think this intervention could be for women all across the world, not just in Pakistan?
Yeah, I think that CBT is one of the most evidence-based, most researched interventions out there. So, based on the way that they kind of adapted it in the study, I think it's great that they took into consideration the differences in culture and the way that CBT could be used for more rural areas. I think that's pretty relevant to the study and the participants here. I did also appreciate the way that they used healthcare workers in the area to deliver the CBT intervention. I think that would allow the participants to kind of take it in a lot better and not be taking in the stigmatized views that they might have and things like that. The short-term training is also something that I noted could be more effective for a study like this, and seems like the results were quite effective as well. And CBT is also very easily applicable and explainable to a layperson. So I think that based on all of that, it's a pretty effective intervention.
So
Yeah.
one quick follow-up question to that. So you noted that there was like a difference between like CBT therapy in different like cultures. So like how does that look like? So compared to like an American culture versus Pakistani culture, how you would implement it?
Yeah, and that was a question I had actually. It wasn't actually outlined in the paper, so I was curious.
Yeah.
It just said that they were culturally adapted in terms of the assessments they used. I wonder because, research does show that South Asian populations and actually like Asian diaspora populations kind of show symptoms of depression through more somatic ways rather than, kind of addressing their feelings or their thoughts directly. So I was curious how they assess these participants based on potentially a more somatic presentation, because, yeah, I doubt that they might kind of be as in tune with their emotions as an American person might be, which kind of directs the therapy or treatment in a different way.
Yeah, also you touched on you talked about like the stigma around mental health, specifically in that area. So we were just wondering what do you think like organizations or local organizations or like healthcare providers like in Pakistan can do about like reducing the stigma associated with the mental health, and like how that can help the woman more, or like have them reach out more to,
And like, how would that look overall?
Yeah. Sometimes I think that South Asian populations and potentially Pakistani populations in particular could diminish the seriousness of any symptoms they might be facing and may not report, may not feel safe reporting. So I think that reducing the stigma by highlighting the effects of the maternal mental health on their newborn or on the infant could be a particular way to go about it. Just kind of noting like this is for the safety of your child and potentially for your family and kind of everyone's well-being, because it is a more patriarchal society. Moms might be more inclined to note their symptoms or report accurately if they're considering the family as a whole rather than themselves. So that was something that came to mind for me. I also think that drawing the parallel between mental health, physical health, and how they're related could be beneficial, because, as I said, mental health is still pretty stigmatized. It could be beneficial to kind of equate mental health with, kind of caring for yourself, going out for regular checkups and physicals and things. So that might help to make it seem more serious than what the participants might already consider.
Yeah. And kind of like on that note, since this was a very small scale intervention, since it was only about 15 to 20,000 people, I was just wondering how difficult it would be to scale this up to meet millions of people, and to kind of treat this major issue on a greater scale.
Yeah, I do think it would be kind of a big feat to scale it up, and I think it would have to be done in a more realistic way. So, for example, continuing an effort like the one in this study, but across several small subsets of rural areas across Pakistan or maybe other countries with this kind of stigma, I think that could be beneficial. I think in a country like that, and especially rural areas, word of mouth can really be utilized as a benefit and a way for participants to share their experience with other family members in the country or even out of the country and kind of spread word that way versus doing it in a more like clinical or scientific context.
And as well, you mentioned it being a lot more like rural based, this intervention. What do you have any ideas on like what kind of funding could go into that? Because it's especially harder to get funding out to more rural communities with already like kind of subpar health systems. So what kind of funding, like who should be heading that funding to kind of build up this intervention?
I imagine likely international government funding would be needed rather than like a local Pakistan-based government. So I did see that. I think the study was carried out by a research center in the UK. So I think it would have to be outsourced to other countries that have the means, the resources, and the understanding of these mental health needs in those populations. I know like here in America, we do have pretty good efforts for rural care, both physical, medical health care and mental health care. So it could be something that we outsource here and then kind of send over to other countries or international rural areas.
So
But I think it would come from a large scale source.
on like that note of using like international resources, how sustainable would that really be? Because I feel like that would kind of be like a constant input if it's not locally based.
Yeah, it would have to be, I think, a project like this where the researchers or the scientists are essentially heading that project and kind of are the spokespeople for the funding here. So there would have to be a number, maybe a small handful or a team of representatives that are in charge of, kind of applying for, receiving, and advocating for that funding. And I think that without that, I don't know that these people in the rural areas would be able to advocate. I think creating a team of, workers that are responsible for it, including people like the lady health workers in the study, people that can also kind of be the representatives for the country, also kind of teaming up with the international spokespeople as well.
So you mentioned the specific teams of people, and I was actually wondering, like, it's only specific to female health workers in this case. Do you think that bringing in men as well to work with these patients would be beneficial, or do you think it's more beneficial to the patient to only them being the same gender?
In this study, I do think same gender was probably the most beneficial. Again, being that it's a patriarchal society and there is still high rates of interpersonal violence and domestic violence in South Asian communities, I think that male health workers, again, might not receive accurate reporting. There might be issues with safety, assault, potentially, just things that occur, especially being that the study took place in these maternal mothers' homes. So I think that it would be difficult to include male health workers. So I did appreciate the effort that they took to get such large numbers of women who were health workers in this case.
Would you give the same answer if this was to be done in the US?
Probably, yeah. I think our research shows that, in same gender relationships across the board, especially in a healthcare setting, there is more accurate reporting. So I think that would be more reliable in terms of the data that you're gathering.
Makes sense. Lori, Lexi, guy.
Oh, sorry.
No, you're good.
No, yeah. Also just like talking about like maternal depression, like the cause of everything. In what ways do you think like the intervention could be improved in order to improve the effects of maternal depression? Or like how do you think it could be improved to make the numbers even lower for like mothers experiencing like chronic prenatal depression?
Yeah, I wasn't sure, I didn't see this highlighted in the paper, but I think having a more maintained or higher sustained effect of the intervention, so like doing it beyond the study, it didn't mention if patients were monitored beyond I think it was like 1 year max postnatal. I think that if it were scaled up to be more long-term study, that's also a way to deliver the intervention for a longer time and potentially gather more data to be used in other arenas, more papers, more studies. It can kind of use more assessments and things like that. It might also help the moms in the study become, I guess, more well-versed with the intervention itself, and they might not need the health workers to come and deliver the intervention instead. That is kind of a facet of CBT, is that you get homework and you get to kind of apply the homework that you learn in therapy outside of therapy. And so that would essentially allow the moms and the families to make use of the intervention in their own lives. So I think that they did include a homework component I saw in the intervention, but I think if it were a little more sustained, it could have greater effects.
That makes sense. And then also speaking about the improvements about this intervention, what do you think about the statement that each lady health worker is responsible for about 100 households in her village? And about 96,000 health workers in this program account for more than 80% of Pakistan's rural population. How do you think this program can expand their employment opportunities to avoid overworking these healthcare workers, and in what ways that overworking could eventually lead to ignoring moral codes and all of that stuff?
Yeah, I think that, it was great that these lady health workers did have like a qualifying education for this. So I think that that might be the way to kind of gain more healthcare workers across the board, is by ensuring that the country or that area specifically can provide quality secondary education, and ensuring that, more people are aware of the requirements to become that type of employee or worker. So I know that may not be possible with the resources in those villages and those areas, but I did get curious like how those existing lady health workers got the education, so they could again use word of mouth to spread the word and do advocacy work and things like that.
And then do you think that specifically trained mental health professionals are morally or ethically required to at least do some work helping communities for little to no pay, since a lot of the members of the served communities don't have the money in order to pay for the mental health services that they'd be receiving?
I do. I'm a strong advocate for that. I think in most mental health professionals ethics codes, it's actually in there of like making sure services are accessible and can be provided to a large number of demographics and populations. So I do think it's just a part of the work that we do, and it should be done, kind of like service with a smile kind of attitude. And I think that's the way to actually work on destigmatizing mental health overall.
Okay, perfect. Tori, you got it?
Yeah, sorry. We were wondering, like, are there any other factors of this intervention you think are like really important to consider and avoid in the future in order to have like the most positive effects on members of the community this intervention is targeting?
Yeah, I think, like I said earlier, if it was possible for the lady health workers who lived in the area to continue providing the intervention outside of the study, again, they must have been pretty well versed in it by the time, because it's over a year of delivering the intervention overall. I think including community support would have been also effective in this case, and would have been another culturally sensitive adaptation to CBT intervention. It's, South Asia is kind of more of a community-oriented place. So I think that that might have helped deliver the intervention, or again, create that sustained effect overall.
Yeah, that makes sense. So if you were to kind of like take over this intervention and make it your own, what things would you add or take away to make it more successful?
I think that I might do a longitudinal study instead. And although that is kind of difficult to fund and difficult to keep track, there's higher dropout rates. I think the data is a lot more salient, and I think that it could really show that impact of the way that maternal health impacts children, and as a result kind of impacts the entire family unit, and as a result the whole community. Like, it's kind of a large scale impact, and I think that that message wasn't necessarily outlined in the study. So that's one thing that I would want to kind of use as a baseline for the study overall, of like, this isn't just about the infant or the mother, it's about the community and actually the entire rural area in some sense.
Yeah, no, it makes a lot of sense. So we're kind of like nearing the end. So one last question for you. How do you think the outcomes of this intervention will affect these women once they do end up giving birth? And what are the opportunities you think that will arise from having better access to mental health resources?
Yeah, I think that this is a way for the mother to be prioritized, which is likely not something that gets to happen in a natural way. And being that depression is often cyclical and can be a recurring disorder based on someone's environment or life circumstance and things like that, the longer the intervention is utilized, the better, she can do in terms of her own health, and as a result, her family's health.
Perfect.
I actually have one final question. So by giving the mothers these treatments, do you believe that the children will also have like better mental health and a lower risk of depression as they grow up, or do you think it won't really matter? It's just based off of the environment they grow up in, I guess?
It's a mix of both. I think it can go 50-50. I think that it could certainly help in improving outcomes. But again, the kids would go to school and kind of grow up around peers and things. But I mean, household factors are one of the kind of greater predictors of adult mental health issues. So yeah, if you're doing well in the home, that can at least lessen any impact of mental health issues that come up later on in the child's life.
Okay, perfect. I think that's all we have. Thank you so much for your time. We really appreciate it. You were a great help and a great guest. So thank you.
Thank you so much for being so accessible over email and everything.
Yes, thank you so much.
Yeah, of course. This is great. I think this is a great initiative and I'm all about it. I thought it would be much longer. I reserved an hour, so now I have time to do stuff.
Well,
thank you so much.
Thank you so much.
Thank you.
Take care.
Bye.
Good
night.
We want to thank our amazing guest, Miss Ganesh, for joining us on today's podcast. We got some great insight into the effectiveness of this intervention within the population, the possibility of scaling up interventions of that type, and what plausible improvements could be made.
We can see that this intervention was a great start. However, it needs to be sustained for a longer period of time to make a true impact. This is difficult, however, as it forces the creators to find funding for a topic that is not greatly discussed across the world, especially in low-income areas.
Before we sign off for the day, though, we want to give a brief overview of the results that were actually published regarding this intervention.
It was noted, and the following is a direct quote from the published paper, that mothers in the intervention group had lower depression scores and lower disability scores at both time points than did mothers in the control group. Similarly, mothers in the intervention group had better overall functioning and perception of social support. The differences remain significant when adjusted for baseline scores of each measure: mother's age, education, parity, infant sex, and socioeconomic status.
Hence, by that measure, the intervention will be seen as a success in the eyes of the creators. To continue, results showed that untreated maternal depression was linked to infant undernutrition substantially and independently, even in the intervention group.
This takes us back to the whole point of the intervention. Maternal depression doesn't only affect the mother, but also her children and family. To continue with positive outcomes, infants in the intervention groups were less likely to have diarrheal episodes, contraceptive use by mothers increased, rates of exclusive breastfeeding increased, and play-related activities between parents and children also increased in the intervention group.
Many would see this intervention as a success. However, as mentioned earlier by our guest, this intervention was not sustained, so we have no long-term data to base any results on. Clearly, however, this was a short-term victory for fighting maternal depression within Pakistan, and hopefully we see more interventions like this one pop up in the areas in the future.
Mental health is an incredibly serious topic, and if you're a loved one who's dealing with mental health related issues, please reach out to a healthcare provider, or don't be afraid to reach out to one of the many resources within your school or community. We hope that everyone has learned more about this important intervention and continues to learn more about how we can help these women. Case studies are important to analyze, as we can always be making improvements to better the lives of everyone.
We'll be back next week with another episode about the effects of organic chemistry on young biology and chemistry students at the University of Maryland.
Make sure to follow us on Spotify and Apple Podcasts. We're trying to beat out Joe Rogan for the #1 podcast in the world. This has been Seth
And Lexi.
Talk to you all again next week.